Yeah, my MRI showed that I had a stroke, and I was sent to a neurologist to be evaluated for this. And we see a lot of people with MRIs that show they have a stroke. And I saw a guy yesterday who had a seizure, and he came in and he had a big, large posterior parietal infarction. And it was not acute on the diffusion wave imaging, but he'd had a stroke, and that scar from that stroke caused him to have a seizure. So what do we do? I mean, do you need to do something to help prevent yourself from having a stroke? Well, generally not, unless you're between 40 and 70 and you have a high risk for stroke, like you have atherosclerotic disease, cardiovascular disease, low bleeding risk. You probably should take a baby aspirin, 81 milligrams a day. You only need 30 to 50 milligrams of aspirin in your body to block cyclooxygenase everywhere in the body, so you don't need much. What do we do to address risk factors if we see someone with MRI of the brain? I think it's not real clear what you should do, and a lot of people just ignore this white matter disease. But I like to define people's risk factors for stroke and look and see what I can do to prevent them from having more strokes. Well, two types of strokes, they're hemorrhagic strokes and they're ischemic strokes. I see very few hemorrhagic strokes in the office. The common types of strokes that we see are very large anterior circulation strokes, and they're, the worst kind to have. Most commonly involve the middle cerebral artery distribution, paralyze you on one side of your body, or sometimes just your arm unless you were your leg. And then, you can get just a partial anterior circulation stroke where you just get a little bit of the middle anterior cerebral artery. You also get these lacunar infarcts when they're occlusion of the deep penetrating vessels, and you can get pure motor strokes, pure sensory strokes, and asymptomatic strokes. And then posterior circulation strokes in the back of the brain, brainstem, cerebellum, and you can have very unusual symptoms of balance, dizziness, lightheadedness. Symptoms that are not normally, a TIA, or symptoms that stay, confusion, headaches, loss of consciousness and coordination of the limbs, numbness that doesn't go away, weakness that does not go away. So most of the lacunar strokes are all from small vessel disease. There's not a tremendous amount you can do for this, but we want to get people to focus on a 3-year plan to lose weight, get their blood pressure under control or blood sugar under control. And they are at risk for stroke, so a baby aspirin a day oftentimes can keep the doctor away. Cardioembolic strokes, we generally can see this on an MRI if we see multiple acute infarcts in multiple parts of the brain. They may be coming from the heart or somewhere else. So take a good history, see if you can figure out what happened. Some of them have no history, some have motor weakness on one side, sensory loss on one side, and then we do the workup. First of all, the MRI, most of the time in the office, they've already had the MRI. And they come in, then we do sort of a coagulopathy workup and look for a younger person, all the genetic things that can cause stroke. Check a CBC to see if their blood is too thick, liver and kidney profile, lipid panel, check their LDL, HDL. Protein C and protein S deficiency can cause stroke. Factor V Leiden is a rare defect, but I see people often that have this. Check your carotid arteries to see if there's any blockage in your left and right carotid. Do an echocardiogram. We prefer a transesophageal echo, where you look down the throat with a tube. The sternum is so big, the transthoracics don't see mural thrombi, which are blood clots in the left atrium, very well. And then so few people get event recorders because they're hard to get, but they need up to 30-day monitoring. See people that jump in and out of atrial fibrillation, and they go from a good rhythm to a bad rhythm and cause stroke. So what are the treatment options? And the treatment depends on the subclinical stroke type. If it's a non-cardiogenic event, we use aspirin, Plavix, or Agronox. Don't use Agronox much anymore. It can cause headaches. Aspirin and Plavix are once a day. If they have a blockage of the carotid, we recommend endarterectomy. The stenting of the carotids comes and goes, and I generally defer this to the vascular doctor. A severe intracranial stenosis, or really at only super specialized neurosurgery programs do we do, angioplasty of intracranial vessels, and this is something we completely defer. Atrial fibrillation, anticoagulation, the old drug Coumadin, but now we use a lot of Eliquis, other new anticoagulants. If they have a PFO, patent foramen ovale, we do percutaneous closure of this if they're a young person. So that's why we like the TE. You'll never see this on a transthoracic echo. So most of our patients take aspirin or Plavix, the vast majority of them. Cardioembolic, most of them take Eliquis, sometimes take Xarelto, some take Prodax. They don't use Coumadin much anymore. So we really just try to define their risk factors for stroke and put them on antiplatelet. You know, if you have a stroke or TA and don't do anything, your risk of having a stroke or heart attack 33 to 50% within 2 years. And it drops down to 1 to 3% if you are worked up and treated appropriately with one of these antiplatelet drugs. It's very important to define people's risk factors for stroke. It's a very simple explanation of what we do in stroke, but I think it's pretty basic knowledge that you'll need to know. And this is Dr. Caldermuller, Brain Doctor. Like, comment, subscribe. More later.